Well, hi everyone, and I'm really happy to be presenting this work on the short and medium-term effects of Sure Start on children's outcomes. I'm going to be discussing the work that a large team of collaborators based at the IFS, as well as UCL and University of Bergen, have done together over the last, I'd say, 10 years. So to motivate why we wanted to look at this particular program, Sure Start, let me start with a couple of motivating facts. So there is much evidence to show that many social issues and stubborn policy challenges have their roots in the earliest years of life. To illustrate this, we know that there are really persistent educational inequalities. For example, if we look at the 2019 GCSE cohorts, we see that there was an almost 30 percentage point gap in the likelihood of receiving good English and math GCSEs between children who were eligible for free school meals, so children from lower income backgrounds, and their more affluent peers. However, if we trace back for this cohort to where how these two groups actually fared earlier in their educational journey, we already see the existence of these kinds of gaps already back at age 5, at the very beginning of school. Here is this measure of school readiness, as measured by a good level of development. And already in this cohort, there was more than a 15 percentage point gap between children eligible for FSM, free school meals, and other pupils. This is just an example of how the early years play a role in kind of setting the foundations for later learning and later well-being, and why there is actually so much research that is focusing on this critical period of life. That research has also looked at the potential that intervening in the early years to support child development by enriching children's environments, whether at home or in early education settings, can have on outcomes both early and later in life. And that body of evidence has shown that early years interventions can improve an array of socio and economic outcomes. It can prevent problems from occurring later on. And by being particularly effective to improve the outcomes of disadvantaged children, these types of interventions can also play a key role in reducing later inequalities. Because prevention is often cheaper than a cure, often these interventions can be cost-effective and have, therefore, for all of these reasons, actually attracted the attention of many governments over the past 20, 30 years. And we've seen really a significant increase in government spending on the early years internationally, but also in the UK and in England, which is the context we'll be studying over the last 20 to 30 years. Interestingly, that public support for spending on the early years has actually been seen across party lines. The Labour Party has always been pretty supportive of investment in early childhood. At the moment, the Secretary of State for Education has actually made the early years her #1 priority. And does, based on the knowledge that ensuring the best start in life can transform life chances for individuals. But that belief in the power of early childhood was also seen among some conservative politicians, and in particular Andrea Leadsom, who as a health minister very much pushed for investment in early years, and especially in the first 1001 days of life. Now, so we are now in a situation where we do have evidence that early years interventions can have, significant impacts on children and on inequalities in outcomes between groups. And we also see increasing support on the policy side for early investment. However, when we look more closely at the evidence base and the more recent evidence base looking at early years interventions, we do actually see that impacts of some of these programs can actually be mixed. There are programs that have no effects. There are programs that also show effects in the short run, but those effects can fade out. And this is particularly true when we look at programs that are implemented at scale. Those tend to have smaller impacts and not always sustained impacts. And so that really raises a question around, what really can work at scale, how those programs should be designed, and what can we hope really from them in the short and long run. And that really brought us to sort of be very interested in Sure Start, a really key early years policy in England, both for the innovation it brought in terms of the program design, but also for the significance of the policy and I would say political investment and support for the program. So let me now say a little bit more about the program Sure Start. So Sure Start was introduced by Tony Blair's government, really as the cornerstone of English early years policy through, and that became such through the 2000s. If we go back to the Comprehensive Spending Review in 1998, where the program was first introduced, the review laid out pretty clear and ambitious goals for the program. And it said the package of Sure Start services will work with parents to promote the physical, intellectual, and social development of the children served. So we see here first a quite holistic perspective on child development, an aim to improve multiple dimensions of child development, and also a recognition of the role of the family and of parents in promoting the development of children. Now, how did the government back then hope to achieve these aims? Well, the answer was to set out a network of one-stop shops that would offer an array of services for families with children under the age of 5. Local areas had quite a lot of discretion in designing and choosing the services that would best meet the needs of their local population. But broadly, those services fell in across were represented across 5 categories: early learning and daycare, parenting support, pre- and postnatal health community services. And so that would include things like antenatal support, but also breastfeeding support, maternal mental health after birth, as well as support for children with special education needs. And lastly, there was also some support for parents that were wishing to get back into training or employment, for example, by linking those one-stop shops with job center pluses. The first one-stop shop, the first center, was opened at the end of 1999. And then from then until the end of 2010, we essentially see a massive expansion of that network to reach over 3,500 centers by 2010. And that expansion was accompanied and supported by a massive public investment as well. And by 2010, so really at the peak of the program, the government was spending about £2.5 billion a year on the program. And at the time, it represented around a third of total early years funding. The other 2/3 were essentially spent on childcare subsidies. Now, given the quite holistic aims of the program and the variety of services that were made available to accessible to families, let's think a little bit about how Sure Start was actually hoped to affect these outcomes. Well, there are, I'd say, at least 4 kind of broad sort of mechanisms. The first one was through the direct stimulation and care that the centers provided to children. And those would have been provided through the childcare and daycare services that was offered there, as well as direct sort of health services that were offered by community nurses, for example, baby waiting clinics or things like that. Then a big component of Sure Start, as I mentioned earlier, was to actually support parents in their parenting. There were many activities for parents to sort of drop in, like play and stay sessions, toy libraries, rhyme time, as well as more intensive sort of parenting programs. In addition to this, parents were able to access a lot of information about healthy behaviors around, how to keep the home environment safe, or about healthy food, weaning, etc. As I mentioned, there were also maternal mental health support that was available in the centers, and that employment support could have also sort of helped foster a more stable home environment, for example, by providing opportunities for parents to get back into the labor force and to increase their family income. Lastly, those centers, and that was very much the idea behind bringing all the centers, under the same roof, was that perhaps a mother would have gone to a rhyme time session, but she would have also, had she had some concern perhaps about her child's communication or language development, she might have been able to pop in and talk to someone about these concerns. And that could have easily led then to a referral to see, to see more a specialist, for example, and then provide more support for, early special education needs. And likewise, you could imagine that the center might have facilitated referrals to social care services, but it might also have facilitated a referral and access to actually appropriate healthcare that for health issues that could not have been provided in the center, but parents might have had the right kinds of interactions, say with nurses in the center, that would have then led to them using, going to the GP or going to the hospital when needed. And then lastly, another mechanism that could have affected those outcomes was through the sort of social mixing that may have happened in the centers. They were very much thought as like community spaces, bringing members of the neighborhood together. And as a result, that could have changed as well, which families interacted with each other and also which children interacted with each other. Now, in this project, we very much hope to provide a very comprehensive evaluation of Sure Start. I'd say comprehensive in a number of ways. The first one is in the breadth of outcomes that we wanted to look at to reflect the very holistic aims of the program. And as I'll describe in more details later, we've looked at academic, emotional, behavioral health outcomes, as well as contacts with specialist services. Comprehensive as well, because we looked at the entire period during which the program was rolled out from the late 1990s to 2010s. And that covered two distinct phases of the expansion of the program. The first being the local programs in the first 4 years, which very much focused on the most deprived communities of England. And then the second big phase, which was the expansion of Sure Start Children's Centres, um, which essentially aimed at universalizing access to these amenities. And the aim in that second phase was really to have one center in each community of England. And then the last way in which the evaluation aimed to be comprehensive was by covering the entire population of children. And here is where the access to administrative and linked administrative data sets played an absolutely crucial role. And that enabled us not only to increase the robustness of the methodology that we use to evaluate the program, but also enabled fine kind of heterogeneity analysis to look at how impacts varied across subgroups of the population. Our evaluation was not the first one to look at Sure Start. As the program was rolled out, the government commissioned two evaluations. The first one was the National Evaluation of Sure Start, NES, which focused very much on the first phase, on the local programs. It used survey data that had been collected as well for the evaluation, as well as the Millennium Cohort Study. And then the second evaluation was the evaluation of children's centers in England, ECCI, which then focused actually on children's centers in the early 2010s, and which, unlike our study, very much focused on patterns of usage and trying to link much more in a more detailed fashion than we were able to the relationship between different service usage and outcome, something that we weren't able to do in our evaluation because we do not have national individual level data on service usage. So that just shows you how, our evaluation kind of built, but also complemented existing knowledge at the time about Sure Start. In terms of our evaluation, the key research questions were, well, what was the impact of accessing Sure Start while growing up? I'll say a bit more about this, but here we're very much interested in understanding how opening and how this rollout of the programs over time essentially affected children in the local communities. We wanted to, and we had the benefit essentially of looking at this policy, many years after it happened. So we were able to look at whether the effects of the program would persist beyond early childhood when children were eligible to use those centers, and how did Sure Start affect different groups of children. We were hoping to make both a policy and academic contribution. On the policy side, we thought that it was actually really important to assess whether the significant public investment had actually achieved its intended objective, and to shed light on what potential these kinds of approaches have in terms of improving outcomes, which outcomes are they best at improving, which are they not improving, and for whom. And in terms of the academic contribution, as I set out earlier, we were hoping to add to the evidence base knowledge about how a major and large scale integrated early years program could affect children's outcomes. And one innovation of our work was to be able to really trace out these effects, the effects of the programs, essentially on outcomes from early childhood all the way to adolescence across a large array of outcomes, using, as I will describe in a few slides, a robust evaluation methodology. So, now, let me speak about the methodology. So we used a large number of administrative data sets to cover all of the domains that we were interested in. When we looked at health, we specifically looked at hospitalizations as well as authorized absences, which are primarily sickness absences. And we used, for hospitalizations, we used the hospital episode statistics, and for authorized absences from school, we used the National Pupil Database. Then we looked at academic attainment at age 5, 7, 11, and 16, and also used the National Pupil Database. We also looked at the same ages at the likelihood of children to receive special education needs support, and we were able to distinguish between SEN support from more intensive education, health, and care plans, also using the NPD. We and then we're interested in looking at whether Sure Start had impacts on children's behaviors. We didn't, in the administrative data, we did not have a direct measure of that, but we looked at unauthorized school absences, as well as suspensions and exclusions, which are often linked to behavioral difficulties. And then we also used understanding society, and to estimate impacts on externalizing and internalizing behaviors among adolescents. We then also looked at impacts on the children's and families' contacts with social care services by exploiting the children in need and children looked after data sets linked to the NPD. And we were able to look at both the number of episodes as well as the nature and length of episodes as children in need or children looked after. And last but not least, we also made use of the more recently linked MOJ NPD datasets to look at offending behavior. And so some of our outcomes were the number of offenses that children committed between the age of 11 and 16. And we were also able to look at the type of sentence and the type of offense or severity of offense that they committed. So really large number of data sets to cover a large number of outcomes. And, with the exception of the hospital episode statistics and understanding society, we worked in the SRS environment and are incredibly grateful to both ONS and ADR UK for, supporting and for everything that they are doing to enable researchers like us to work with these kinds of data sets. Now, a few words on methodology before I turn to the results. So here our focus was on estimating the impact of having access to a Sure Start facility, so a local program earlier on, or a children's center, on the outcomes I just listed. By having access, we really mean, as I mentioned, but this is important, these centers were basically open access to families living in the neighborhood. There was no strict catchment area that would dictate who was eligible to use or not. But the idea, and there is evidence to support that, was that these centers were aimed to be within walking distance or prime pushing distance, as we see in a lot of documentation of the time, for local families. And so we were very much interested in measuring the impact that essentially having and opening these centers in an area would have on those families that live close by and that would have access to the facility. And so in this sense, this is very much an intention to treat, because we know that the take-up of these services was far from universal in these, close by. But it is essentially the impact of, opening rather than necessarily using those services. To be able to measure access to the Sure Start facilities, we made use of, on the one hand, data on the date of opening and the location of every Sure Start local program and children's center that opened between 1999 and 2010. And then we combine this data with data about the location of children when they were growing up. Depending on which data we used, essentially we had to construct slightly different measure of access. For all outcomes except hospitalization. So all of these other data sets essentially have, the NPD as the main data set or the basis for linkage. We knew we were able to observe children's postcode at age 5. So in the first year, they appear in the school census. And therefore, we were able to measure access as living within a perimeter of the center. And we defined that perimeter as 2.5, at this radius is 2.5 kilometer as a walking distance, but we also did lots of robustness checks and sensitivity analysis to other definitions. So, and then in the hospital episode statistics, we didn't have such fine information about where children lived. So we defined access as the number of centers that were open when the child was 0 to 5 in the local authority of residence per 1,000 children aged 0 to 5. And to construct that, we used the child's area of residence at the time of a hospital admission, rather than at, necessarily in early years, because we just didn't observe it. I have to say that this analysis now would, one could do it with each child, linking the NPD and HES, but at the time, each child did not exist, and so we weren't able to use it. Now, our aim was, as I said, to estimate the impact of having access to a Sure Start facility. And so one might think that we could compare the outcomes of children who had access and therefore live closer to a center with the outcomes of children who live farther and didn't have access. However, that's kind of naive comparison wouldn't necessarily estimate the impact and identify the impact of Sure Start, because it could confound the impact of the program with the many other systematic differences between children who lived closer and children who lived farther. Indeed, the rollout of Sure Start, as I mentioned earlier, was based on deprivation. And so if we just looked at the entire period, children who tended to be more deprived actually had more access than children who were less deprived. And so we would be comparing essentially these two groups who may have different outcomes because of many other reasons, but their differential access to Sure Start. So to circumvent that challenge, we use instead a difference in difference methodology, where we are essentially going to be looking at trends in outcomes within a small area. So think an LSOA. I'm going to be looking at how outcomes change across cohorts. So some of these cohorts will not have they will be born too early to have access to Sure Start. Some of these cohorts will have had access to Sure Start because they were born, after a center opened. So we're going to be looking at the change in outcomes between these cohorts. And then we're also going to be comparing these trends in outcomes across different areas. For example, an area that actually did not have a Sure Start center for a really long time, and that could serve as a comparator area. And by doing that, we're able to not only control for the nationwide factors that might have affected outcomes over time, but also for all those time invariant and areas, so in our case, LSOA level kind of determinants and characteristics that might have affected outcomes in absence of Sure Start. This strategy essentially recovers the causal effect of having access to Sure Start on outcomes, as long as those areas that are used as comparators would have had essentially the same trends in outcomes as areas that receive the programs earlier in absence of Sure Start. And we run a number of validity checks to ascertain or to increase our confidence that this assumption actually holds in the data sets. For example, we check whether the trends in outcomes between these areas with different kind of rollout of Sure Start and that we use as control and treated. Actually, those trends before Sure Start was introduced were similar and were parallel to each other. And indeed, we find much evidence of that, which gives us confidence in the method. Right, so now it is time for me to start telling you about what we find. So first, a key finding that we highlight in the research is that Sure Start really benefited children's educational attainment. So starting at age, so here on this graph, I'm going to be plotting the effect of living within 2.5 kilometers of a Sure Start center on test scores. Those test scores are standardized. And so how to read this graph is that at age 16, children who had lived within the 2.5 kilometers of a Sure Start center in their early years, where almost 5% of a standard deviation had GCSE scores that were almost 5% of a standard deviation higher than children who had not had access to Sure Start while in the early years. And we also looked at, for example, the impact of Sure Start on the likelihood to get 5 good GCSEs, so A star to C grades at the time. And we estimated that the effect of living close to Sure Start was to increase the likelihood of getting 5 good GCSEs by about 1 percentage point, so which is really a non-negligible impact. Now let's see what impact Sure Start may have had even earlier than 16. We see that those impacts were already visible through primary school at age 7 and age 11. And at age 5, when, at the end of reception, when that measure of school readiness is taken, we do see a positive impact, but it is too imprecise to conclude that is definitely different than 0. When we break down the foundation stage profile by different dimensions of development, it covers things like numeracy, math, communication and language, understanding of the world, etc. We do find significant impacts on communication and language, but the impacts on other dimensions are not significant. They're positive, but not significant. Next, we also looked at special education needs, and we do find evidence that Sure Start ultimately reduced children's special education needs. What's really interesting here with this outcome is that we actually see that at age 5, having access to Sure Start actually increased children's likelihood to receive special education needs, so early on in their educational journey. But then from age 7 onwards, we see a reduction in that. And so this kind of speaks to the possibility that Sure Start actually played a key role in earlier identification of special education need, perhaps putting in place the right support earlier on to reduce actually the later need for support. Interestingly, we see that those impacts were concentrated among SEN support, so the less intensive form of support, but when it came to more intensive plans, education, health and care plans, Sure Start did not have an impact. Now let's move on to another kind of dimension, interesting dimension of school engagement. So we do find that Sure Start also seem to have increased learning time, and by that I mean that it reduced school absences. I don't think I will show the impacts on authorized school absences, but here I show the impacts on unauthorized school absences, which are already visible from the age of 6 all the way to the end of primary school, and then which increase in magnitude during secondary school, during which unauthorized school absences become more frequent. And we see that by age 15, essentially, children who lived closer to a Sure Start center, who had access to Sure Start in the early years, essentially had a 0.15 school days less than they had missed, that they would miss in the year. And then we turn to health, where here, so as I said, it's a slightly different measure of access. So it's the effect of an additional Sure Start center per 1,000 children in the local authority, and it's the effect of that on hospitalizations. And here we're looking at all causes of admissions, and we find that, well, interestingly, up to age 5, so while children were eligible to go to a Sure Start center and to receive services, we actually see that an increase in hospitalizations at age 1, like in infancy, and then those increases, and the magnitudes are not trivial. We see a 10% increase in the probability of being hospitalized at age 1. Then these positive impacts reduce in size, and around the age of 4 actually start turning negative, so indicating reductions in hospitalizations as a result of having access to Sure Start. Not all impacts at every age are statistically significant, but they are at a couple of ages. But what's really striking, and what we delved a lot more into, was why we saw this pattern with more hospitalizations early on and fewer hospitalizations later on. And to help us understand that, we essentially rerun the analysis looking at different causes of admissions. So first we looked at hospitalizations for preventable causes. So these are, for example, for chronic conditions that can be managed outside of hospital, such as asthma. And what we see here is the striking increases in hospitalizations like earlier on for preventable causes, and then those reductions. And so what we kind of understand this pattern as potentially suggesting is that through the information and the support, the health support that families may have gotten in the Sure Start centers, they might have been able to discuss, say, with community nurses, with health visitors, some of their concerns about children's health issues, about children's health, and they would have been appropriately referred to hospital when needed. And you can see that, like, earlier on, there is, those might have led to more kind of referrals to appropriate healthcare, with then an impact later on actually really reducing the hospitalizations for these causes. We also looked at infectious diseases, where we see quite a different pattern. Again, earlier on, especially at 1, we see an increase in hospitalization for infectious diseases. And then around the age of 4, we see that those actually become reductions in infectious diseases here, and then there are no longer like significant effects later on. One hypothesis that could explain these results is that Sure Start brought children together in centers. They brought children more in contact with each other than it would have been otherwise, and that in the short term might have led children to become more sick, but then that might have actually helped build their immune system, leading to reductions in hospitalizations for infectious diseases later in the early years. But that negative effect essentially kind of stopped by like the age of 8, when all children would have been in school anyway and in contact with others, and their immune system would have caught up. And then lastly, on health, we also looked at external causes. Here, a very interesting, a very different pattern where we actually see that Sure Start led to reductions and really large reductions in hospitalizations for external causes. So these are accidents and injuries. And here, those reductions, we hypothesized they might have been they might have been driven by changes in children's behaviors, which are often linked to accidents or injuries, but also they might have been linked to, safer home environments, thanks to the support that parents were getting in the centers, thanks to the information they were receiving on how to keep, a child-proof and safe environment. So those would have essentially led to that reduction essentially in hospitalizations, through primary school. Now, just mindful of time, so I'm not going to go through all of the other results that we have, but I will refer to our kind of capstone report that we published last year, and that really brings all the strands of the research together. But I will note that, to sort of counter a little bit the very positive picture of Sure Start and the impacts that it had, the benefits that it had for children, we also find that the program did not affect every single outcome that we looked at. And in particular, we find that it was less effective on the more severe outcomes that we considered. As I mentioned, we found no evidence of an effect on education, health, and care plans, neither in the short or medium term. We also looked at offending, and we found very limited impact of Sure Start on the proportion of young people with a criminal record by age 16. And lastly, we found very limited impact on children's interactions with the social care system. Now, so I will skip those slides, which essentially spoke to these results. Just to say one word about the heterogeneity of impacts that we found. So, those effects that I talked about on education, health, they were really quite widespread across, a lot of different subgroups. But in some cases, we did find some evidence of larger effects for some groups, and in particular, students from who were eligible for free school meals, so from lower income backgrounds, may have experienced bigger benefits, especially in terms of health and potentially in terms of education. We also find quite strong evidence that boys may have experienced larger effects than girls when it came to more kind of like behavioral outcomes. And quite strikingly, we also found in the education analysis that non-white children tended to experience larger benefits. Now, we pulled all of these results to try and calculate the cost and benefits of the program. As you can imagine, many of these outcomes were associated with significant financial benefits or costs. And now, all these cost-benefit analysis, are inherently uncertain. Many of the benefits are still in the future. In some cases, we try to predict them over the lifetime, but this really should be seen as trying to give a sense of scale and providing a best estimate, but definitely not a highly certain number. The way that we approached this was to estimate the benefits and costs for a representative cohort at the peak of Sure Start. And so that is why we essentially compared the direct and the upfront cost of Sure Start in 2010, which in today's price was around £2.8 billion. And we compared that to a series of different benefits. First, benefits to individuals through increased earnings, but also other benefits from, for example, lost earnings from increased earnings from reduced hospitalizations. But also then we looked at the government benefits, the benefits to the exchequer, both in terms of the increased tax income that the government would have received from increased earnings resulting from those increased GCSEs, as well as reduction in spending for government on things like youth justice, special education need, and obviously healthcare. And we estimated all those benefits to amount to about £5.8 billion, and so almost twice as large as the upfront cost of Sure Start. I'll finish with just a summary of findings. So as I've discussed, Sure Start benefited children and young people's health and education and likely had inequality reducing effects. We do find more mixed impacts on children's socio-emotional and behavioral outcomes. But what's striking is that many of the impacts that emerge in early childhood actually manage to sustain at least until the age of 16. And that essentially drove, as per our calculation, the long-run benefits to significantly exceed the cost. And again, I will repeat because this is so has been so instrumental to enable this research. The administrative data sets and linked data sets that we use really made all of that possible. We won and we're incredibly grateful to have won the Research Excellence Award for Impact of Analysis. So I just wanted to finish with a few thoughts on the public policy impact that the research had. Essentially, this Sure Start is a bit of a historical policy. After its peak in 2010, the country again, entered a period of austerity, and the funding for the program first lost its ring fence, but also, reduced by at least 75%. And so we basically had 15 years of pretty much of a decline in this kinds of approach locally, but also really a lack of policy direction like in this space. And so I think what the research essentially did was to strengthen the case for this type of integrated family support in the early years, so that the debate could really move from should we have these kinds of approaches that bring services for families together for the local community, to how can we actually make this happen and how should we design this for families, living in 2025 and not in the early 2000s. And I think that has kind of helped reinvigorating these approaches, which are now about to be rolled out via the Best Start Family Hubs policy again. When we published the research, the education strand, it was widely picked up in the media and by senior labor figures, including Gordon Brown, who had been very involved in the rollout of Sure Start in the early days, which very much called for, these kinds of programs being reinvigorated. And that was before the general election in 2024. And then a year after the election, we had now a Labour government in power, a Secretary of State that was very keen on the early years. And I think the research, which is referred to a lot in Bridget Phillipson's early year strategy, essentially is helped making the case for why we would want something like Best Start Family Hubs. All of that would not have been it would have not been possible just by having, the research and a nice report on the website. We engage in very extensive formal and informal in formal and informal ways with policymakers, but a much wider array of stakeholders. And we were incredibly well supported by our comms teams at the IFS in order to really kind of pick the right kind of communication strategies for the right stakeholders. And obviously we benefited quite serendipitously by, the timing and the changing political context, which meant that, there were also people in power who were interested in listening to this research. So I'll stop here, and I'm sorry